sorrow's lament and compassion's on trial, I will belong to you.
91.3 WVKR Independent Radio, Poughkeepsie, New York. I will play that track again. It's Rachel Sage and the Sequins. She'll be playing Sunday in Woodstock. But right now, I am going to get our next guest on air. Hello, Dr. Curcio, are you with me?
I'm here. Can you hear me?
Yes, I certainly can. Thank you from the bottom of my heart for taking the time to be here with us today on this show. As you know, you have been my doctor for the past year. This show is all about music and the arts in the Hudson Valley. And you're the first medical professional I've had on. And I thought that it would be really important because it's Breast Cancer Awareness Month. And I, for the first time on air, am going public about my journey and that I was diagnosed a year ago. And you as the medical professional, I just wanted to have you on to give your insight. And you are my doctor. You are one of 3 doctors I currently see. And when giving those women that diagnosis, because you called me, and how that just makes it feel surreal for a minute, and then you go into your plan of action.
Mm-hmm. How I do that?
Yeah. Yeah. You sat down with a pen and a paper, and honestly, I have to tell you, I didn't realize there were so many different types of cancer. Okay, I just did not.
Right.
I just thought cancer is cancer is cancer. Holy crap, you're there. You've got this. I've got this. And Donna Lewis, my guest, also had a HER2 positive, which is what I have, which I now know is a bitch of a cancer. And
right.
So I don't know. Just start talking. I mean.
Okay. So, nowadays, most of our breast cancer diagnoses are done in the Department of Radiology. So sometimes we'll see someone with an abnormal mammogram, and then we send them for the biopsy. But unfortunately, a lot of times we have to call them and give them the diagnosis over the phone. And I think that's one of the most difficult parts for me, is having to tell someone when you're not there in person that they have cancer, because you can't see their face, you can't see their expressions, you can't have that person-to-person connection. But that's oftentimes because I've tried where, like, let's have you come in and we'll talk about your biopsy, and then right away they're like, oh, cancer, what? Tell me now. Right. I don't want to come in. So, right. It kind of makes it a little bit more difficult to do it that way. But what we try to do, even though we oftentimes have to give the diagnosis by phone, is to get the patient in pretty quickly, like usually within 24 or 48 hours, so that we could sit down with a game plan. And I always try to encourage patients not to come alone, right, but to come with another set of ears, because oftentimes, the studies show that you only hear about 20 to 30% of what a doctor's saying when you're dealing with a cancer diagnosis.
Right. Yeah, 100%. There are things now, a year later, that I'm like asking that I know have been told to me before, but I don't remember them.
Right. And oftentimes what we do too is, at least I like to do, is we give you, we actually have this like little PowerPoint presentation that we have the slides printed out. And so we can give you pictures of the different things that we talk about, like the estrogen receptors and the HER2 receptors, just as something you could take home and kind of look at and say, oh, this is what she was talking about when she was talking about the HER2.
Right.
So that really helps a lot of times too. And then if you remember at the end, we kind of have a treatment summary. So this is what you have. This is your stage. This is the size of your tumor. I think you could have a lumpectomy, or if you can't have a lumpectomy, you need a mastectomy. And then, like, what do we need to do to get from point A, which is diagnosis, to the next step,
Right.
And so we give patients kind of a to-do list, but then what happens oftentimes is they put that in the little folder we give them, and they never go back and look at that to-do list. But we, my office staff, my nurse navigator really helps
Alicia.
to make sure. Yes, Alicia
Yes.
Brophy. She's amazing. She is like the force for the patient. She's the concierge that walks them through every step of the way, and she makes sure that you're checking your to-do list, and we're slowly crossing off every item so we can get to the next step in treatment.
I cannot imagine those first few weeks after my diagnosis without her giving me a plan of action and just like here's your little folder, here's your checklist, call this, do this, make that appointment. I also, by the way, I don't know if I formally introduced you. I do want to tell listeners that we are talking with Dr. Lisa Curcio, who's a board certified general surgeon and fellowship trained surgical oncologist. You're the current medical director of breast surgery at Northern Dutchess Hospital in Rhinebeck. So I should have preempted all of this with that. But anyway, that's what we're doing now. And now, can we talk about stages of cancer, please? Because I think that until you've diagnosed, you've known that typically there's 4 stages. And if you could just elaborate just a little bit about that. And I'm guessing it depends on the type of cancer that you have and all of that.
So the staging is more what we call anatomic staging. So it's based on the size of the tumor and whether or not the lymph nodes are involved. So we have stage 0, stage 1, stage 2, stage 3, and stage 4. So the easy ones are stage 0 and stage 4. Stage 0 is what we call non-invasive breast cancer. That accounts for about 40,000 new diagnoses every year.
Wow.
And that's where the cancer started either in the ducts or the lobules, but hasn't spread outside of the ducts or the lobules. So that's what we call in situ cancer. So that's stage 0.
And
then
that's found by early detection, I assume, yes?
Absolutely. That's usually a mammographic finding. Rarely it can be something that someone feels on exam, but more commonly it is something on the mammogram, and most commonly it's like little dots of calcium that we see on that black and white mammogram.
Okay. And then obviously, and this show is all dedicated to, and the reason I'm coming out is because I really, if we can encourage somebody driving in a car right now or listening to this show or listening to the recording later, we're so busy in our lives, right? Oh, I know I need to get that mammogram. I know I need to go get that test, but I'm just so busy. I'll do it next month or something. I just want to stress how important it is to get that test.
Absolutely. As women, we take care of everyone and put ourselves last always.
Yep.
And, what we need to realize is if we don't take care of ourselves, all those people that we take care of aren't going to get it taken care of. So we know that if a cancer is found in the breast by a mammogram before you can feel it, the cure rate is anywhere between 95 to 99%.
Amazing.
I mean, it's tremendous nowadays. Mammogram truly does save lives.
Yeah, it really does. And ultrasounds as well, if you can get both. I'm always a proponent of getting both, right? If you're at high risk, sometimes you can do that. I think I was doing that. I was doing mammogram in the summer and an ultrasound in the wintertime or something.
Right. So mammograms are the best screening modality. And if you have dense breast tissue, you should always have a supplemental ultrasound with your mammogram because those are the people that we could miss on a mammogram. And then if you're high risk like yourself, yes, we can alternate mammogram with ultrasound as a screening modality.
Right.
Correct.
Right. And I was at super high risk and had a little MRI, which is how we found my cancers. And
Correct. Yours was just a screening MRI, which, everyone's not a candidate for a breast MRI.
Right.
Insurance company, unfortunately, they hold very high standards for those people who qualify. So you have to have a certain level of risk to qualify for an MRI.
Right, because of my familial history with both grandmother and mother. So not everybody, I understand, is for that. The early detection, though, is so key, so key. And where was I going to go with this? So, Dr. Curcio, you you make this very personal, and because it is personal for you, because you are
Correct.
also a survivor.
That's correct. That's correct. I was diagnosed with stage 0 breast cancer in 2000, 9 months after I had my first child.
9 months. Wow. Wow.
Yeah.
Did you find it yourself? Like, did you feel it?
I had a symptom. I was breastfeeding and I pumped some blood. And I, initially kind of thought, well, maybe it's just from some trauma from, those breast pumps.
Yep.
And really kind of talked myself out of overreacting, but then found a little bit more blood on my bra. And then I had one mammogram prior to this. I was only 37 at the time,
Wow.
but I had diagnosed someone who was 28 with breast cancer. So I got a baseline mammogram, which was normal. So I repeated my mammogram. I ordered my own mammogram.
Amazing.
Doctor, do not treat yourself. And later that day, I was in the biopsy suite getting a biopsy. Yeah.
Wow. Wow. Amazing. Amazing. And yeah, so for you now to be in this field and being a breast surgeon and a rock star at it, I might add, you are renowned in our area. You are a top doctor, and I am so glad that you're on my team. I couldn't imagine it. So um, there's just like that, I don't know. There's so many things I want to ask you that I don't even know where to start. The thing that's always a big question is, how old are you supposed to be when you start testing? And it always seems to go back and forth depending on insurance or whatever year we're in. What's the right age to start getting a mammogram?
So, I think, unfortunately, the task force several years back really confused things. So you have to look at the average risk woman. So someone who, unlike yourself, does not have a family history, does not have any risk factors for breast cancer. The average woman starts screening at the age of 40
Right.
and should be getting yearly mammograms moving forward. Now, if you're someone who has a strong family history, it has to be individualized. But in general, we do recommend starting screening at least 10 years prior to the earliest age of diagnosis in your family.
Gotcha. Okay. Okay. So when you get all these, I mean, you know what I have found out a lot this year? It's been exactly a year ago since you gave me that call. And then we started quite the plan of action that for me, and I can talk about it. I know you can't, but I can. I can say that I had surgery, and then I had chemo, and then I had radiation. And I still tomorrow will be in an oncology unit with infusion, which is a targeted therapy for my HER2 aggressive cancer. And every cancer that you have, like really, I know this is a stupid question, but how many cancers are there on the breast? Like hundreds?
Well,
or
it depends. So there is a different subtype, like it starts in the ducts or it starts in the lobules. And then there are different personalities of those different types of cancers. So, for instance, some breast cancers are what we call hormone sensitive, which means that they respond to your body's hormones, and then they can be treated with what we call endocrine therapy, which is an anti-estrogen therapy. There are some cancers, like your own, that could be hormone positive or hormone negative and have the HER2 amplification. Those are called HER2 positive breast cancers. And then there is an entity called triple negative, which are negative for all of those things, negative for estrogen, progesterone, and HER2. And those are called triple negative breast cancers.
Okay, and the most aggressive form of breast cancers are?
I would say that the triple negative is the most aggressive, although we have made tremendous strides because now triple negative breast cancers are being treated after a certain size or if lymph nodes are involved with immunotherapy, which has really improved the survival of triple negative breast cancers.
Yeah. It really it must have really come a long way in like the last decade or two, correct? Breast cancer?
Absolutely, absolutely. So much has changed even since my diagnosis in the early 2000s.
Yeah.
In terms of how we look at breast cancer, who gets chemotherapy, how we decide that. It used to just be based on size, stage. If you had a bigger tumor or your lymph nodes are positive, you get chemotherapy. But nowadays, certainly the more aggressive variants like triple negative and HER2 positive, we already know that those people are going to get chemotherapy. It's just usually a matter of, do we do surgery first or do we do chemotherapy first?
And that
And
depends
then
on the size of the tumor, right?
it's based on, yes, the size of the tumor, and different characteristics like whether or not the lymph nodes are involved too.
Right.
And then some of the other tumors that are not HER2 positive or triple negative, even if they have a larger tumor, we do a test called an oncotype now. And not everyone that we would have treated 20 years ago with chemotherapy because they were more than 2 centimeters, if you do an oncotype, which actually looks at the genes that the cancer expresses, and these are the genes that would allow the tumor to spread. And if they express highly these genes that allow the cancer to spread, then there's a big benefit to chemotherapy. But if they don't express these genes and they come back with a low score, then there's no benefit to chemotherapy. They just go on the anti-estrogen treatment.
Amazing. I mean, this was all something new. I remember clearly you saying you're getting chemo. I said, no, I'm not. No, I'm not. I'm not doing chemo. And I remember that because I think, honestly, that word scares the crap out of people. It just does. We've all seen the movies. We've all seen what can happen. And I can say now that my chemo ended in April. And while it was something I hope to never repeat in my life, I made it through. And
You did?
this year has taught me, I knew I was strong, but I didn't realize even how strong I was. And the strength that I also got from your team. And I have to say, those nurses in the oncology units are angels from heaven. Okay. And those people, those patients that you sit next into those reclining chairs, we're all about 6 or 8 feet apart, and we all have stories. And those stories I've heard over the last year have inspired me to get through this. And it's been such an amazing journey, so one that I'm so grateful for my detection. And that's why we're going public with this on air, because it's so important for women to get tested and for men to get your exams and for colonoscopies. There's all this medical stuff right at our fingertips. And I just don't want people to be scared, because we're all, most of us, way stronger than we think we are.
It's so, so true. And so many times, unfortunately, I see in my office someone who's paralyzed with fear and doesn't act, and then has to face a advanced cancer diagnosis. And sometimes, to a point where sometimes the cancer's treatable, but not necessarily curable. And if they had just kind of gotten beyond their fear of the mammogram or the results of the mammogram and done the test, we could be dealing with a much more curable situation.
Right.
So fear can it's choosing not to decide is really deciding that you're going to let this, go on and on and
Right.
take, sometimes even take your life. So, fear has to be overtaken, and there's nothing to be fearful of, because a mammogram nowadays, it's very quick test. The compression is computerized, and most women don't complain like they did in the past about the pain of the mammogram.
Right, right. And especially, honestly, if you've given birth before, really just suck it up. And that's me, I mean, really, it's 2 seconds. It takes next to nothing of pain at all. And I have to tell anybody that is diagnosed or newly diagnosed, don't let the biopsy scare you. I was scared beyond belief to get that done. It wasn't bad. It wasn't like, there's so much numbing stuff that you're given nowadays. I really, even surgery through you, it didn't, the first day, okay, it hurt. Yeah, of course it hurt. And, but it's all manageable now because of the medicine at our fingertips.
Yes, sometimes we can, when you picture something in your mind, you could blow it up to be so much bigger than what it really, really is.
Absolutely.
And I just wanted to go back to something that you said earlier, though, too. You know, sometimes someone with an early stage breast cancer, it's a small tumor, it's less than 2 centimeters, which is a stage 1. But yet, I'll say to them up front, you're going to need chemotherapy because you're HER2 positive or you're triple negative. And they'll be like, well, how could I need chemotherapy if I have this small stage 1 breast cancer? And part of that is, you know, when we used to treat based on size and lymph node status, we would say to patients, your cure rate's really good. It's like 95%. Well, if it's small and it's not in the lymph nodes, why isn't it 100%? And it's because a small percentage of early stage breast cancers are more aggressive and they need chemotherapy to deal with any cancer cells that could be in the bloodstream. And so it's very hard for people to understand that concept, that it's not just based on size, that decision for chemotherapy, but it's taking size and lymph node status into consideration, but looking at, I like to call it the personality of the breast cancer.
Right. Right. Yeah. And also, you know, I also want to talk about two more things. Pills. Like this is okay. I'm a year into my treatment. I'm going to be 10 more years into this because I have to take pills to prevent reoccurrence. How effective are they? And I know that tamoxifen is premenopausal and letrozole is post. Can you talk a little bit about the drugs?
So these drugs are given to women that, under the microscope, when we look at their cancers, they're expressing the estrogen receptor, which means that they need the estrogen to continue to grow. So the job of these drugs, and there's 3 in this category, anastrozole, letrozole, and exemestane. And these drugs actually prevent the production of estrogen. Even though women are postmenopausal, they don't understand that they're making a chemical in their adrenal gland that can get converted into estrogen. But in order for that conversion to occur, they need an enzyme called aromatase. And these medications inactivate that aromatase enzyme. So they really put people into what we call a very deep menopause. Now, there are women that go on these medications and have very little side effects, but there are other women that have side effects. And the side effects can be joint symptoms, muscle symptoms, vaginal dryness, pain with intercourse,
low
hair
energy.
Loss. Low energy.
Yeah. But then I think the body also tries to acclaim to that. You can't just automatically give up because I was told if this pill doesn't work for me, we'll put you on another type, but it's just a different thing, you know. So,
right.
But there's side effects to any. It's the first prescription. Like somebody like me has never been on a prescription pill other than antibiotic or something. To have to now take something and be dependent on it. You know me, I try to fight everything. I'm like, no, I'm not going to do that. I'm not doing chemo. I'm not taking that pill and I'm putting that off. And, you know, and I realize I'm just shooting myself in my own foot because if you do the math, these pills that I have to take, it's called letrozole, it's reducing my risk from instead of 20-30% of it coming back, I'm down to 10 to 15% of my cancer coming back. That's half.
Correct.
That's half. So.
That's correct. Here's the other thing I like to, I always like to look at the glasses being half filled, not half empty.
Right.
People who don't have hormones, say you had a hormone negative HER2 positive breast cancer, then you wouldn't have the opportunity to take something to prevent your breast cancer from coming back. And, you know, after you're done with chemotherapy and your year of Herceptin, you just sit there and wait and hope that it doesn't come back.
Right.
But because you're hormone sensitive, you're able to take something that hopefully will prevent this cancer from coming back. And so it's a pretty powerful treatment, and it's in a little pill that you take once a day.
How long has the Kanjinti and Herceptin been around?
So
this targeted therapy.
Herceptin was first FDA approved in 1998, but it was originally for metastatic breast cancer only.
Mm-hmm.
and it was FDA approved for the treatment of early stage breast cancer in about 2006.
Gotcha. Yeah, it might be saving my life right now. Let's talk about that because that's what's on my mind is reoccurrence, right? We now go, I saw somebody else post on that had breast cancer and they now call it scan anxiety. That you go from one scan to the next and you're just waiting for that horrible news. Talk about reoccurrence, please.
So reoccurrence can occur, and that's why we monitor patients very carefully. I think that the whole scanxiety thing, in patients who have had chemotherapy and know that they have more aggressive cancers, they tend to have, I think, a little higher level of anxiety with all of their studies. And, the good and bad news is most people who have like HER2 positive breast cancers or triple negatives, they are more aggressive cancers and they tend to come back early on. Whereas people with the HER2 negative, hormone positive breast cancers, some of those breast cancers can come back 10, 15, 20 years later.
And when they come back, you find them on a mammogram, a blood test? How do you find them?
There's all different kinds of ways they can come back. They can come back in the breast. They can come back in the lymph nodes. And both of those are very curable and treatable. Or they can come back distantly, the bone, the liver. And it's treatable, but then it's not curable because then that's when it's stage 4 breast cancer.
Yeah, there's a lot. You see all these drugs, metastatic breast cancer drugs that are out there. I just heard about somebody that's alive, stage 4 cancer, metastatic cancer, and they're 4 years.
I've known patients that had presented with stage 4 metastatic cancer like yours, HER2 positive. So when they initially came to us, it was already spread outside of the breast. And over 10 years, they are without evidence of disease. Now, they're still taking the Herceptin. They're still going every 3 weeks for the Herceptin infusion. But and Herceptin is what we call a targeted agent. They're so powerful, they could take someone who's got widely disseminated disease or widely spread disease and put them into remission and keep them in remission for long periods of time.
It is amazing. My mom had breast cancer 30 years ago. Unfortunately, I don't know what kind she had, but the treatments that have come since our parents had cancer is mind-boggling to me. And I meet these people in the oncology unit, and I just blown away because you use, at least me, layperson, not a medical person, stage 4, oh my God, death sentence, okay, quite honestly. But it's not.
No. We have, for other types of breast cancer, we have treatments that can keep people alive for many years. Now, not all cancers read the textbook and not all cancers respond optimally, but a lot of the cancers we have nowadays, we can put into remission for long periods of time.
Right.
So although, that person with stage 4 will likely die of breast cancer someday,
Yep.
It doesn't mean it's going to be today or tomorrow or the next year. It could be, 5, 8, 10 years from now,
right,
or longer.
And that's all because of the drugs that are available now. Had that diagnosis come 25, 30 years ago before these targeted therapies came, it might have been a lot different story. So,
Absolutely.
So I want people not to give up and not to give up hope, because when you're told you have cancer, the first thing you think of is, I'm done. Okay. You just do. And now, having me personally gone through this for a year, I'm not done. I'm just starting out, Dr. Curcio.
Exactly.
And I just, thank you for what you do, because your job is not easy. Your job is not easy. It is, you see people with all stages. You see people that aren't going to make it. You see people that are. But to tell somebody and to tell a woman and sit there with all those graphics and all those papers, that's got to be hard. And you see a lot of patients, and you do this every week. You tell women they have cancer, and you've had it yourself.
I think it's a gift to be able to walk them through the journey and try, a lot of what we do in the office with these papers, not overwhelm them, not make them feel like there's just too much information, but really kind of educate them and make things less scary so that the next physician they see, they're like, oh yeah, Dr. Curcio talked about different types of endocrine therapy, and she talked about this. So the job is to kind of empower people by educating them as much as we can about this. This isn't as scary as it seems, and it's certainly not a death sentence.
Absolutely.
A cancer diagnosis nowadays is rarely a death if it's found early.
Absolutely. Absolutely. And that's why it's important for early detection. And that's why I go into all these post office. It seems like every post office in my area has pink balloons and breast cancer awareness and just making people mindful. Get that test. You held a beautiful event I unfortunately could not attend last Wednesday. Tell us what you did.
So we had this event called Pink Fest, and it was to kind of kick off our Light the Village Pink campaign, which is about breast cancer awareness. And all of Rhinebeck and Red Hook and parts of Eastdale now are, lit up with pink lights. Again, to remind people to get their mammograms, and also to remind people that there are people in their community, 1 out of 8 women have breast cancer, and these people, have gone through treatment or going through treatment, are survivors of breast cancer, or to remember those who weren't survivors that lost their battle to breast cancer. So it's just, every day is Breast Cancer Awareness Day in my office, but October gives us an opportunity to really get in front of the public and remind them that breast cancer is curable. Mammograms are great screening tests, and we can cure cancer that's found on a mammogram. And you just need to get out there and get the study scheduled. And it's so easy. Nowadays, you don't even need a prescription from your physician.
Right.
You can just call up if you're not having any breast symptoms, and it's a screening mammogram, and you can get a mammogram at all of our facilities at New Vance.
Yeah, absolutely. Dr. Lisa Curcio, board certified general surgeon, fellowship surgical oncologist. You are the medical director of breast surgery at Northern Duchess Hospital. You have offices in Rhinebeck and in Kingston, correct?
Yes.
And you are the rock star. You are the absolute rock star. I can't imagine having walked this journey and continuing to walk it without you. I thank you for holding my hand, for being tough when I needed it, because I can be a pain in the ass, and you just give it right back to me. And I love, love, love that about you. And I honor you, your profession, and what you've done for hundreds of women, if not thousands at this point. And you really are a rock star. You're the rock star. Not all the musicians I talk to, you're the rock star. I thank you. Big hugs to you. I see you on Friday, and I thank you for your time with us today.
God bless you, Rita. Thank you.
All right. I'll talk to you. Thank you. Bye-bye. 91.3 WVKR, independent radio, Poughkeepsie, New York. Dr. Lisa Curcio, board-certified general surgeon, fellowship-trained surgical oncologist, medical director of breast surgery at Northern Duchess Hospital in Rhinebeck. Breast Cancer Awareness Month. That's what this month is. That's what we're doing, folks. That's what we're doing. I'm your host, Rita Ryan, here with LocalMotion. If you missed part of that interview, I'll be uploading it likely tomorrow, and that's with Dr. Curcio. The first hour, the guest was Donna Lewis, who also is a survivor of breast cancer. So please go get your mammograms. Please go get your tests. Men, women, get your PSA, get your stuff. Get your stuff. It's all out there, folks, and it's not fun to go through. I'm not very going to say that. But it's not as bad as you think, because medicine has come so far. So I'm going to play another track. Then we're going to do musical happenings. Right now we're going to listen to a performer who will be at the Town Crier Cafe in Beacon on Friday night, the legendary singer-songwriter Tom Rush, 91.3.
Get on home, you've been gone too long. At 14 years I left my home, the moon was in the trees, Mama's voice was in my ears, calling after me. And springtime in the breeze. At 14 years I turned my back, my fortune for to find. I set my feet to rambling around, standing around in the gambling towns, wasting time like wine. And hey, glory, now glory road, sing hallelujah, you better get on home, you've been gone too long. Wash cars and 10 bars and can't be proud to take a loan. Gets cold and grow old and can't be scared to be alone on the glory road. I ain't a man to worry much, I very seldom pray. Pray right now I see my home when springtime passes by this time. Springtime comes that way. And hey, glory, now glory road, sing hallelujah, you better get on home, you've been gone too long.
91.3 WVKR Independent Radio, Poughkeepsie, New York. The legendary Tom Rush, the album Gardens Old Flowers Now, the track called Glory Road. He will be bringing his music to the legendary Town Crier in Beacon this Friday night. That's Town Crier, spelled with an E.com, for tickets and information to see their great lineup and Tom Rush this Friday night. It's time for musical happenings. It's this part of the show, the end of it, where I list in alphabetical order some of our area venues in the hopes that you go support live music in our wonderful world-class area venues. Starting with the Assembly in Kingston. Tickets and info, assemblykingston.com. Tonight, the Woodstock Film Festival starts by airing the Honky Tonkin' in Kingston. That's happening tonight, October 24th, Ashley Gavin at the Assembly. The Bardavon and UPAC. Tickets and info, bardavon.org. October 17, Modest Mouse. October 22nd, Il Divo by Candlelight. Bearsville Theater in Woodstock and at bearsvilletheater.com. October 21, Mike Viola. October 22, Joshua Radin. October 23, Early Elton. City Winery in the Hudson Valley in Montgomery, New York, and at citywinery.com. October 16, Floyd Pink. October 23, Feast of Friends. Colony in Woodstock and colonywoodstock.com. Thursday, Shakedown City. Saturday, the Pink Floyd Project. Sunday, Rachel Sage and the Sequins with Annalise and Ryan. And every Monday is an open mic at Colony. Howland Chamber Music Series at Howland Cultural Center in Beacon. Tickets and info, howlandmusic.org. November 2nd, the Acropolis Reed Quintet. The Falcon in Marlborough and live at thefalcon.com. Tonight at the Falcon Underground, the Blues Jam hosted by the one and only Carl Allwire. Thursday, the Record Club presents Clearance Clearwater Revival Chronicle. Friday, Daniela Cotton. Saturday, Chris Berkson featuring Ellis Hooks. And Sunday, La Bamba and the Hubcaps. Fisher Center at Bard College. Info at fishercenter.bard.edu. October 25 and 26, the Bard Conservatory. Jazz Forum in Tarrytown and jazzforumarts.org. October 17 and 18. 2 shows each night. Lou Tobacco Quartet. The Local in Saugerties and at thelocalsaugerties.com. October 17, the Golden Age of Latin American Boleros with Miramar. October 19th, Desert Blues with with Tarwa and Tinariyi. The Stissing Center in Pine Plains, also at thestissingcenter.org. October 17, Theater on the Road presents Dracula. October 19, Tommy Mesa and J.P. Joffrey. Tarrytown Music Hall in Tarrytown and also at tarrytownmusichall.org. October 16, Pink Martini. October 17, Marty Stewart. Town Crier in Beacon and towncrier.com. Every Thursday is an open mic. Friday on the salon stage, Chris Brown. Friday on the main stage, Tom Rush. Saturday on the salon stage, Henry Furland. And on the main stage, Total Mass Retain, a Yes tribute band. Sunday brunch with the Lake Trio, and Sunday evening, Jeff Daniels. And last but not least, and it's starting right now as we speak, happening now, the 26th annual Woodstock Film Festival, today through Sunday. Tickets and info, woodstockfilmfestival.org. You can also take a listen to the last couple of interviews I hosted with the executive director of the Woodstock Film Festival, Mayra Blaustein, and also the two filmmakers. They've got films premiering at the Woodstock Film Festival. So much fun. Check out their website. Oh my gosh, I'm leaving right now to go up to Honky Tonk, up to see the film that's out up in Kingston, and I hope to catch some of you there and to just support live music, and today was quite a show. Thanks everybody that listened to it, that is sending me messages, that took the time. I feel open, I feel liberated, quite honestly. And please go get tested. Please go get your mammograms, your ultrasounds, your colonoscopies. It all can be done. I wish to say a huge thank you to Donna Lewis, my guest during the 4 o'clock hour, and a huge thank you for her time, Dr. Lisa Curcio, breast surgeon up in Rhinebeck, part of the Nuvance Medical System. She's the director up there in Northern Dutchess Hospital. She also has an office in Kingston, and she's been my doctor and my go-to for the last year, and just absolutely amazing. With that said, I'll be back